Dr. Preethi.
HARADA syndrome as secondary angle closure glaucoma, a case report. A 44-year-old male presented with chief complaints of pain and redness in both eye for 1 week, which was acute in onset associated with headache. He was a known diabetic and hypertensive for past 5 years on regular treatment. Anterior segment examination showed diffuse bulbar congestion in both eye. The anterior chamber was shallow with one Herrick grade 1. Pupils were sluggishly reacting to right. The undilated fundus showed a hyperemic disc. The intraocular pressure in right eye was 18 mm of mercury and left eye 22 mm of mercury. Gonioscopy showed closed angles in both eye. Clinical diagnosis of both eye primary angle closure with mild elevation of intraocular pressure in a middle-aged male with no previous history of ocular treatment was made. Patient underwent both eye YAG peripheral iridotomy. Next day, following a laser peripheral iridotomy, patient came for review and his anterior chamber was still shallow and the PI was not patent. However, the intraocular pressure was only moderately elevated. Both eye occluded PI and patient was advised for enlargement of PI on both eye. 4 days following a repeat laser PI, patient presented to us with sudden onset of loss of vision in both eye. His vision in both eye has decreased to hand moments from 636 and 624 in right and left. The both anterior chamber was still shallow. The laser PI was not patent. Then the dilated fundus examination was done. The optos wide field image of both eyes shows a clear media, a hyperemic disc, the tortuous vessel. The background retina shows a multiple convex elevations with corrugated appearance suggestive of total serous retinal detachment in both eye. The ultrasound B scan of both eyes showed a smooth, a dome shape, hyperechoic elevation lines with underlying hypoechoic spaces suggestive of both eye total retinal detachment with 360-degree choroidal detachment with mild vitritis. The OCT of right eye, both eyes showed thickening of the inner retinal membrane with indulations of the RPE and choroid were showing indulations, and they were in the hypoechoic spaces we could find precipitates. The FFA was done, but the posterior pole view was not clear due to retinal detachment. However, the late phase showed some hyperfluorescent, mottled hyperfluorescence. The diagnosis of VOGT KOYANAGI HARADA syndrome was made, and patient was made to admit in a hospital due to lack of glycemic control. Patient was started on first dose of pulse therapy of cyclophosphamide over 2 to 3 hours with intramuscular dexamethasone injection once a day for 3 days during the hospital stay. Sorry for this PowerPoint. These are the blood investigation which showed uncontrolled glycemic sugars, and his liver enzymes also were started to elevate. The second dose of intravenous cyclophosphamide was given 15 days later the first dose, and then patient was shifted to oral cyclophosphamide and steroids in view of rising liver enzymes. His vision gradually improved from hand movements to 6/9 in both eye. This is a comparison picture showing after 2 intravenous injections of cyclophosphamide, and the resolving retinal detachment and the choroidal detachment. The VOGT KOYANAGI HARADA disease is a bilateral, chronic, recurrent granulomatous panuveitis with neurologic cutaneous manifestation with instance of angle closure presenting as an earlier sign in 4 to 10%. Etiology is unknown. We presently diagnose using revised diagnostic criteria proposed by first international workshop on VOGT KOYANAGI HARADA disease. I'm so sorry. These are the complete, incomplete, and probable revised criteria, and these are the stages: prodromal, uveitic, chronic convulsion, and chronic recurrent. The pathogenesis behind the angle closure is due to the anterior rotation of the ciliary process and supraciliary space with raised IOP, causing the anterior chamber to become shallow due to ciliary body movement, and this causes the transient angle closure attack. We report this case for its rarity, and moreover the laser iridotomy which was performed promptly failed to produce an anterior chamber deepening. It's a challenging case which was treated effectively with combination of immunosuppressants and systemic steroids. We should consider VKH syndrome in patient who presents with bilateral angle closure glaucoma, particularly in populations known to be at high risk. Thank you.
We had a similar case, although it was not so bad as what you showed. But why did you use cyclophosphamide?
So patient was a diabetic.
No,
and
I'm not talking about that. Okay, fine. Anyway, you can even give IVMP in uncontrolled diabetics under good medical supervision. that you can do. But again, then again, if you, okay, fine, starting cyclophosphamide, normally we don't do in the first attack of VKH, maybe second
Recurrence.
attack we do, and then cyclophosphamide is a very strong drug. We have other options like methotrexate and azathioprine, which work equally well.
Okay, sir.
And cyclophosphamide is known to have the highest toxicity among.
Yes, sir.
So that's what you could have gone for a less toxic immunosuppressant.
However, we were keeping a note on his liver enzymes and other levels, sir.
Because rather than steroids will be less dangerous than cyclophosphamide in the long run.
Okay, sir.
Anyway, fine, thank you.
Thank you,
Good
sir.
presentation.